Hi everyone, and in this video, I am going to discuss renal pharmacology. And renal pharmacology, the topic what we are going to discuss is diuretics. Now, what do we understand by the term diuretic? Diuretic is a drug which increases sodium and water excretion in the urine. The basic question is why should we increase sodium and water excretion in the urine, and where to use diuretic? Obviously, we use them when the sodium and water retention is more. Which condition? The conditions where the sodium and water is more is one is edema condition, second one is an hypertension condition, and congestive heart failure. So let us understand where the diuretics work and what are their uses, what are their adverse effects, then contraindications. So let us start our journey. Diuretics. So what do you mean by diuretics? They are the drugs which increase sodium and water. So they increase sodium and water excretion in urine. So they are called as diuretics. So what is the basic use of these diuretics? I told you we use it in the edema condition where there is sodium and water retention. What is the reason for edema? For example, the cardiac reasons. So patient having the congestive heart failure, or because of that patient may develop pulmonary edema. So there we use diuretics. Or head injury, patient may have cerebral edema, or a patient may have cirrhotic edema, or a patient may have edema due to kidneys. What are the reasons in the kidney, the edema? One is the CKD and the nephrotic syndrome. And the nephrotic syndrome, these are the conditions where we see the edema. Another condition where we don't want sodium is in hypertension condition. So these are the basic conditions where diuretics are used. But how do I eliminate sodium and water from our body? The regulation of this sodium and water is mainly done by nephrons. So let us, in the next slide, we go to the nephron, understand where the diuretic works, a bit of physiology, let us understand. Now this is the nephron. You can see the proximal convolutive, the loop of Henle, distal convolutive, and collecting duct. Now the sodium, 100% of sodium is filtered at the glomerulus, and in that 100%, 65% of sodium is reabsorbed in the proximal convolutive. So 100% sodium is filtered and 65% is reabsorbed. 25% of sodium is reabsorbed in, remember the site, thick ascending loop of Henle. And around 5 to 8% of sodium is reabsorbed in early part of DCT, that is distal convolutive tubule. And 1 to 2% of sodium is reabsorbed in the collecting duct. So this is what the reabsorption pattern. Now if I stop the reabsorption of sodium, sodium will go out in the urine, and wherever sodium goes, water follows. But remember, wherever water goes, sodium will not follow. So if I don't allow the sodium to reabsorb, sodium will be lost. When the sodium is lost, water is also lost. And that is what we mean by diuresis. So this is the meaning of diuresis, or the drugs which do that are called diuretics. Now, what are the drugs which act on this? Number one, the drug which act on the proximal convertible PCT. These drugs are called as carbonic anhydrase inhibitor. So the drugs which act on proximal convertible, they are called as carbonic anhydrase inhibitor, and they inhibit the enzyme carbonic anhydrase. Their major site of action is PCT. Now the second group of drug which inhibit the sodium reabsorption in the thick ascending loop of Henle, they are called as loop diuretics. They are called as loop diuretics because they act on the loop of Henle. Now the drug which inhibit the sodium absorption in early part of DCT, the third group of drug are called thiazide diuretics. They are called as thiazide diuretics. Now you take a minute and try to tell me, among the target 1, target 2, and target 3, which one will have more diuretic action or more efficacy? Now, if you look at the diagram, we think that carbonic anhydrase will have more efficacy. But the point is, carbonic anhydrase are going to inhibit the sodium reabsorption that occurs with bicarbonate reabsorption. Now, sodium is reabsorbed not only along with bicarbonate, it is along with chloride, it is reabsorbed along with glucose also and amino acids. So, the carbonic anhydrase, whatever they are inhibiting, is the sodium reabsorption which is occurring along with bicarbonate. But still, the sodium reabsorption continues along with chloride reabsorption along with glucose absorption. Now, even if you lose the sodium, when you use carbonic anhydrase inhibitor, there is a chance that it is getting reabsorbed back in the loop of Henle. That's the reason carbonic anhydrase inhibitors are mild diuretics. So when you look into the diagram, we think that carbonic anhydrase inhibitor, they are losing 65% of sodium, and we tend to tell that they have high efficacy. No, because we are only interfering one pathway, that is the bicarbonate and sodium reabsorption. But still, sodium is reabsorbed along with chloride, along with glucose and amino acid. And some of the sodium lost is reabsorbed back in loop of Henle, and the very minute sodium is lost. That's why they are mild diuretic. Consider the second category, that is loop diuretic. Now, when you take loop diuretic, how much it is losing? 25%. And if you see that still 8% may be reabsorbed back in the early part of DCT, 2% is reabsorbed in the collecting duct. So even 10% is reabsorbed, you are losing 15% of sodium. So that's the reason loop diuretics are high efficacy diuretics. Loop diuretics are called as high efficacy diuretics. Now moving on to the third target, thiazide diuretics. Now when I talk about thiazide, they are losing around 5 to 8%. So the efficacy is medium efficacy diuretics. Medium efficacy diuretic. Now you please understand the first three targets, the carbonic anhydrase inhibitor, loop diuretic, thiazide diuretics, all these three are derived from sulfur. So all these three are derived from sulfur. So what is the problem? If they are sulfur derived, patient will have allergic manifestation. So these three drugs can cause allergy. That is one basic understanding. Second thing is, all these three drugs, they are tend to lose sodium. Now when they lose sodium, the aldosterone come to the picture, and aldosterone tries to take up sodium inside in collecting duct. To compensate for sodium entry, the potassium goes out. So please remember, the first three drugs, all of them can cause a problem called hypokalemia. They all can cause hypokalemia as the adverse effect. So carbonic anhydrase inhibitors, loop diuretics, thiazide diuretics, they can cause hypokalemia, and all the three are derived from sulfur, so they can cause allergy. Now when we are using this drug, patient may suffer with hypokalemia. Now how do I compensate that? To compensate that, we have a 4 target of diuretic which act in the collecting duct, and they are called as potassium sparing diuretics. So the name itself is telling you they will spare the potassium and they don't allow potassium to be lost. So fourth group of drugs are potassium sparing diuretic, and they will only interfere with the reabsorption of 1 to 2%. That's why these are very weak diuretics. So potassium sparing diuretics are very weak diuretics, right? So we know the 4 targets, and number 5, we have one more group of diuretics. They are called as osmotic diuretics. So osmotic diuretic, please understand, they can act throughout the nephron. But in the exam, if they ask you in the nephron which is the major site of action, the major site of action is proximal convertible and loop of Henle. Loop of Henle. So that is a major site. If both are given, please choose the site of action is mainly PCT, but it will act through the entire nephron. So we understood the basics. This is how the diuretics will work, and you know the targets of them and the efficacy of them. Even osmotic diuretics have high efficacy. Okay, so with this basic understanding, let us go one by one and discuss the targets. Clear? Yes. So the first group of drugs, what I am going to discuss with you all, they are called as carbonic anhydrase inhibitors. So these are called as carbonic anhydrase inhibitors. And what is the name of them? The name is acetazolamide. Acetazolamide. Then we have brinzolamide. Then dorzolamide. And one more drug is called dichlorphenamide. So these are the carbonic anhydrase inhibitor. The basic question asked in the exam is, the carbonic anhydrase is inhibited by acetazolamide. Is it competitive or non-competitive? The inhibition of carbonic anhydrase is non-competitive enzyme inhibition. So it is non-competitive. Now they can ask you a correlation with biochemistry. What happens to the Vmax if it is non-competitive enzyme inhibition, and what happens to the Km? Now in non-competitive enzyme inhibition, Vmax. In non-competitive enzyme inhibition, Vmax decreases, Km remains the same. So this was the question asked in one of your exams. The major action is to inhibit carbonic anhydrase. Now let me go in detail and explain to you what is the mechanism of action, how these carbonic anhydrase work. Now this is the proximal connotubule. This is the proximal connotubule. So this is the lumen, and this is the cell nearby. Yes. Now, what is the absorption mechanism? I told you sodium has to get reabsorbed. When the sodium gets reabsorbed, there is outcoming of H plus. So there is bicarbonate present here, and the bicarbonate will combine with H plus to form H2CO3. And this H2CO3 is split up into H2O and carbon dioxide with the help of carbonic anhydrase enzyme. Now this water and carbon dioxide can diffuse inside the cell. So when they diffuse inside, H2O plus carbon dioxide, they will again combine to form H2CO3. So that is also mediated by carbonic anhydrase. Now again you get H plus here, and you will get bicarbonate here. So like this, the sodium is reabsorbed back and bicarbonate is reabsorbed back. This is the normal physiology. I'm not talking about drug now. So this is what happens normally. So sodium has to enter, compensation is H plus coming out. It combines with bicarbonate and they form carbonic acid. They split up into H2O and carbon dioxide. They diffuse in the cell and they form carbonic acid again, and they split H plus and bicarbonate. So sodium and bicarbonate is reabsorbed like this. Now when we use a drug, the acetazolamide, they inhibit carbonic anhydrase. Now when you inhibit carbonic anhydrase, you will not get H plus to exchange with sodium. If H plus doesn't come, it cannot combine with bicarbonate, and sodium is not reabsorbed, bicarbonate is not reabsorbed. So the problem is there is loss of sodium in urine. There is loss of sodium in urine, and that is what we mean by the diuretic effect, and the loss of bicarbonate in the urine. There is loss of bicarbonate in the urine. Now when you lose sodium in the urine, that is what is responsible for the diuretic effect. And what is the point I need to understand when you lose bicarbonate in the urine? So let us understand that. What happens when you lose loss of bicarbonate in the urine? So when you lose bicarbonate in the urine, two important thing is this. Number one, the urine will become alkaline. Urine will become alkaline. So the urine becomes alkaline, it will be increasing the risk of a stone. The stone is called calcium phosphate stones are going to be increased if the urine is alkaline. Second, when the urine is alkaline and you are losing bicarbonate from the body will have metabolic acidosis. So the patient will develop metabolic acidosis because you are losing bicarbonate. And when the bicarbonate is lost, what will happen? Suppose this is the proximal convertibule. This is the proximal convertibule. Now, when the bicarbonate is lost, so to compensate the bicarbonate loss, the PCT will start increasing reabsorption of chloride. So that's why the patient will have hyperchloremia. So it is called as hyperchloremic metabolic acidosis. So please understand, when you lose bicarbonate, two things: the urine becomes alkaline and you will have metabolic acidosis. To compensate the loss of bicarbonate, the PCT will reabsorb chloride and that will lead to hyperchloremia. And alkaline urine will predispose to calcium phosphate stones. So that is the mechanism of action of carbonic anhydrase inhibitor. So once we know this important mechanism of action, so let me write the uses of this carbonic anhydrase inhibitor. So the drug astazolamide, that is a major drug what we use, and that is used in a condition called acute mountain sickness. It is used in acute mountain sickness, and for that astazolamide is the drug of choice. Now, acute mountain sickness is also called as high altitude sickness. When a person ascends to the high altitude, there is hypoxia. When there is hypoxia, patient tends to breathe faster, so he will lose carbon dioxide. It will lead to respiratory alkalosis. To compensate that, this drug produces metabolic acidosis and that will get compensated. Second, the patient in the high altitude develops pulmonary edema, and this is a diuretic, it can take care of pulmonary edema. So that is the reason why astazolamide is the drug of choice for acute mountain sickness. And don't confuse with morning sickness, motion sickness, they are different. It is also used in a condition called acute congestive glaucoma. So it's an emergency. There also we use the drug acetazolamide. It is also used in glaucoma. Astazolamide is used in glaucoma. And astazolamide is also used to correct metabolic alkalosis. Now, why are we using it to correct metabolic alkalosis? Because astazolamide produces adverse effect metabolic acidosis. That's why we use to correct metabolic alkalosis. And it has shown to decrease the epilepsy, that is seizures. So we use it there. These are the uses. Remember, mainly the drug of choice for acute mountain sickness is acetazolamide. Very, very important point. Then the other drugs we have discussed in glaucoma, the DOR, the BRIN, remember them as zolamides. DOR, zolamide, brinzolamide, these drugs are used for glaucoma and these are used as eye drops. And we have another drug called dichlorphenamide. The name is dichlorphenamide and we use it in familial periodic paralysis. They are shown to be effective in familial periodic paralysis. So if you see the uses of carbonic anhydrase, nowhere we are seeing the use as edema or hypertension because these are very mild diuretics. Now coming to the adverse effect. Now when you know the concept, you can tell me the adverse effect. Number one, they cause allergy. Why do they cause allergy? Because they are derived from sulfur. Second, they can produce hyperchloremic metabolic acidosis. So they can produce metabolic acidosis because they lose bicarbonate. Then they can produce alkaline urine. Urine become alkaline. So what is the problem? It will lead to renal stones. And they lose potassium, so they cause hypokalemia. They produce hypokalemia. Along with that, they can also produce somnolence and altered sensation, that is paresthesia. So these are the major adverse effect what we are going to see with carbonic anhydrase inhibitors. Now, one important clinical application you need to understand is these are contraindicated in a patient with hepatic encephalopathy. These are contraindicated in a patient with hepatic encephalopathy. Now, what do you mean by hepatic encephalopathy? It's a condition where the ammonia is high, the liver is not working properly, the liver is damaged. So, this ammonia will enter the brain and that is causing encephalopathy. So, the problem is excessive ammonia in the circulation and that is causing encephalopathy. Now, what happens in the kidney? Let me write the nephron here. This is the PCT. Now, the ammonia is a basic substance. Ammonia is basic in nature. Now, we need to throw the ammonia out, but ammonia can get reabsorbed back. Ammonia can get reabsorbed back and it will worsen hepatic encephalopathy. Now, when I use carbonic anhydrase inhibitor, can you tell me what do they do with the urine? Will they do the urine acidic or alkaline? So, they make the urine alkaline. So, they will make the urine alkaline. Now, you remember the general pharmacology here. Basic compound is ammonia. The pH of the urine is alkaline. So, tell me now the ammonia is ionized or non-ionized. In this environment, the ammonia becomes non-ionized, that is lipid soluble, and it is reabsorbed back. If it gets reabsorbed back, the ammonia levels increases further and hepatic encephalopathy worsens. That's why please remember carbonic anhydrase inhibitors are absolutely contraindicated in hepatic encephalopathy patients. Very important. So we're done with the first target, and that is carbonic anhydrase inhibitors. Moving on to the second target, they are called as loop diuretics. They are called loop diuretics. Let me write the site of action. Where do they work? The site of action of these are, please remember this is very important, thick ascending, because there is thin ascending also. This is thick ascending loop of Henle. That's why they are also called as loop diuretics. And in that they inhibit a transporter called sodium potassium 2 chloride O transport. So they are going to inhibit this transporter. That is the site of action. Now, once you know the site of action, what is the efficacy of this? These are high efficacy diuretics. High efficacy diuretics. Now, once we know this, what are the drugs in loop diuretics? Yes, the drug is furosemide. Furosemide, I know you remember the brand name called Lasix. The name Lasix was given to that because the action lasts for 6 hours. That's why. Then we have a drug called torsemide. Torsemide is a longer acting loop diuretic. Remember it as tall. Tall means longer. And then we have a drug called bumetanide. So bumetanide is most potent. The meaning of most potent, you all know, it is used at low dose. That's it. Remember, all these furosemide, torsemide, bumetanide are all derived from sulfur. So they are sulfur derived. So what is the problem if they are derived from sulfur? We all know that allergy. There is a drug called ethacrynic acid. Ethacrynic acid is not a sulfur, it's a non-sulfur drug. Suppose a patient has sulfur allergy and you want to prefer a loop diuretic, what you prefer is ethacrynic acid. Now, once I know this, let me tell you in detail what is the mechanism, how these drugs work. I told you we have the loop of Henle. Let me draw this. This is the loop of Henle. And tubular lumen. There is a transporter here, and the transporter will take up sodium, potassium, and 2 chloride inside the cell. Now, when we use loop diuretics, these loop diuretics are known to inhibit sodium, potassium 2 chloride entry, and also they are going to inhibit the reabsorption of two ions. Two ions are not reabsorbed. One is calcium and one is magnesium. So basically, loop diuretics, they don't allow the reabsorption of sodium, potassium, 2 chloride, as well as calcium and magnesium. So loop diuretics are going to lose these electrolytes: sodium, potassium, chloride, calcium, magnesium. Now, when it comes to from the loop, they comes to the this thing. From the loop, they come to the DCT. There's some sodium and chloride are reabsorbed. But what happens when they come to the collecting duct? So from loop of Henle, I just tell you, they will come to the which one? DCT. So there some sodium, some chloride is reabsorbed back. But what happens when they come to the collecting duct? So this is the collecting duct. What happens there? So when they reach the collecting duct, who is going out? Sodium is going out. So when the sodium goes out, to compensate for that, the ion that comes out is potassium. So potassium comes out. Now you know that potassium levels are not so much. To compensate for that, along with potassium, there is loss of H+. So the pump is called ROMK pump, that is called renal outer medullary potassium current, and the H+ ATPase pump. So to compensate the loss of sodium, the compensation is done by the excretion of H+ and K+. So when we give loop diuretic, patient will have hypokalemia. Along with that, you are losing H+ out. So what do you see? When you are losing a positive ion, you will see obviously metabolic alkalosis. So loop diuretics are known to produce hypokalemia and metabolic alkalosis. So this is the basics. So all the ions will decrease and it will eliminate sodium in the urine. It will eliminate potassium, chloride, it will eliminate the calcium and magnesium. So all these ions will decrease. There is calcium, magnesium, sodium, chloride, as well as potassium are lost, and it will produce metabolic alkalosis. So once we have understood the mechanism of action of loop diuretics, so it's easier to tell me the adverse effect of these drugs also. So I can classify the adverse effect like electrolyte abnormalities and the other adverse effect. Now they can decrease the potassium, hypokalemia. They can decrease the sodium, hyponatremia. They can decrease chloride. They decrease magnesium and they decrease calcium. Remember, they can lose calcium. So if they lose calcium, there is also a risk of renal stones because you are losing calcium in the urine. Other important problem is these drugs can produce metabolic alkalosis. I told you that metabolic alkalosis, and they are depleting sodium and water. So the ECF will decrease extracellular fluid, and they can cause allergy. Except ethacrenic acid, other furosemide, bumetanide, torsemide, they can cause allergy. And one important adverse effect is ototoxicity. Now, ototoxicity, that is toxicity of the ear. You remember like this, the loop of the ear. Loop. So ototoxicity, and that is maximum seen with ethacrenic acid. So ethacrenic acid, you remember E for ear toxicity, and they also can increase uric acid. So hyperuricemia can be seen. So these are the two major adverse effects what we see with loop diuretics. Now once I know the adverse effect, let me write the uses. Number one, these loop diuretics are used in edema called pulmonary edema. It is used in pulmonary edema. So pulmonary edema, these are the diuretic of choice. So diuretic of choice in pulmonary edema are loop diuretics, particularly furosemide. Now the question is, okay, so you can take a cut here and I will explain from here. So why loop diuretics furosemide is used in pulmonary edema? Let me explain here. Now let me draw the heart here. This is the diagram of the heart, and then the lungs. Yes. So this is the left side of the heart. Now, what happens when the left ventricular failure occurs? When the left ventricle fails, that means it is not able to pump properly. The fluid accumulates inside, and the back pressure is given to the lungs. Now, when the back pressure is given, the fluid accumulates in the lung, and that is what we mean by pulmonary edema. Now, when we use furosemide, the advantage of furosemide is it releases vasodilatory prostaglandins. It releases vasodilatory prostaglandins. Now, what will vasodilatory prostaglandins do? They will dilate the veins in the periphery. So, when you dilate the vein, the blood, the fluid will be more in the vein and less in the lungs. So, that is what we mean by shifting of the blood from. So, it will shift blood from pulmonary to systemic circulation. So, they dilate the vein and that will shift the blood from pulmonary to systemic circulation, and that is an advantage. So when the pulmonary edema decreases, patient can breathe easily. And after that, you will see the diuretic effect coming to the picture. So not only it is a diuretic, it is also a drug which releases vasodilatory prostaglandin. That is the reason why it is a diuretic of choice. The question here is, can we use loop diuretics with NSAID? Can we combine them together? No. The reason is, if we combine together, these vasodilatory prostaglandins will not be able to work, and it will not be able to provide vasodilatory effect. So NSAID with furosemide combination is irrational. So that is the use in pulmonary edema. Apart from that, the drug loop diuretics, they are also used in other edema conditions. It is used in the edema that is cirrhotic edema, and the renal edema that because of CKD, or the edema due to the nephrotic syndrome, we use loop diuretics. Now, I told you loop loses calcium, so we can use it in the management of hypercalcemia condition. Hypercalcemia. Number 4, it is also used in the management of hypertension. Hypertension. Now, for hypertension management, the best drugs, the best diuretics are thiazide diuretics. Now, why loop diuretics are not going to work in hypertension? Their efficacy is less compared to thiazide diuretics. And when do you prefer? If the patient has the GFR less than 30 ml per minute and he has hypertension, then only we use loop diuretics to manage this condition. Why we use loop diuretics? Why not thiazide? Because thiazides will not work in renal failure. I'll repeat again, thiazide diuretics will not work in renal failure. So if the renal GFR is less than 30 ml per minute, patient has hypertension, then you can manage with loop diuretics. So please remember, the major use of loop diuretic is in pulmonary edema, then edema conditions, hypercalcemia, and only in some cases of hypertension. Sometimes it is also used in hypertensive emergency. It is also used in hypertensive emergency. And number 5, it is used in the management of CHF, both acute as well as chronic CHF. So these are the uses of loop diuretic. And remember, they are high efficacy diuretic. They cause increased urinal. So they are not preferred for chronic therapy. If you are using it for a very long period, there is a chance of they develop resistance. So they are only given for shorter period. Now we understood the adverse effect. We understood the other aspect, mechanism of action, and uses, all these things about loop diuretics. The next thing what we are going to discuss, the third target, they are called as thiazide diuretics. They are called as thiazide diuretics. Now in thiazide diuretics, we have a drug called chlorothiazide. Then we have, you add hydro for that, you get hydrochlorothiazide. So these are thiazide diuretics. Now there are certain drugs called thiazide-like They are not derived from thiazide, but they have mechanism similar to that. The name is chlorthalidone. So the specialty of chlorthalidone is it is longer acting. Then we have a drug called indapamide. Indapamide and a drug called metolazone. Now, I told you already, thiazides will not work in CKD, that is renal failure patient. Metolazone is an exception. It will work even when GFR is approximately 15 ml per minute. Even with that, it will work. So this is one important drug you need to remember. Metolazone works even when GFR is approximately 15 ml per minute. So usually thiazides will not work. One important drug you all should remember is metolazone. Right? Even indapamide will work in renal failure, but if they give both the options, please go for metolazone. Now, once you know the drug, let me write the mechanism of action. The mechanism of action is the part of nephron where the work is early part of distal contibule, and they inhibit a transporter called sodium chloride symport. So they inhibit sodium chloride symport. Second, they stimulate activity of parathormone, and by stimulating the activity of parathormone in DCT, they increase calcium reabsorption. So they increase the calcium reabsorption, that is one thing, and they have mild carbonic anhydrase inhibitory property, because these are all derived from sulfonamides. They have certain property like astazolamide, mild carbonic anhydrase inhibition. So please remember their site of action is early part of DCT. So same thing what happens when we give loop diuretics, the sodium goes to the collecting duct, sodium gets inside, potassium comes out, H plus comes out, same thing happens here. Now, writing the use of this, number one, these loop diuretics are used in hypertension and they are shown to be efficacious. For hypertension, without any comorbidity, these are the first choice drugs. These are first choice drugs for hypertension. But will they decrease BP so much? Remember, they are not such a great antihypertensive. They are only mild antihypertensives. They are only mild antihypertensive. They can decrease the BP how much? Around 5 to 10 millimeters of mercury, not greater than that. So number one, we use it in hypertension. Number two, we use it in edema conditions. So edema in the presence of CHF, in the presence of cirrhotic edema, we use these drugs. Number three, these drugs are used because the calcium is reabsorbed, calcium is retained. We use it in the treatment of osteoporosis. So the drugs are used in the management of osteoporosis because they retain calcium. Number four, these are used to decrease renal stones, renal calcium stones. Now, how do they decrease renal calcium stone? Because if calcium comes from the nephron, they will go to the calyx, then the ureter, bladder, urethra. So calcium is not at all coming, then where is the question of renal stones? So if the patient is prone for renal stones again and again, then you can use these thiazides. So they can decrease the risk of calcium stones. Number five, these are used in diabetes insipidus. Diabetes insipidus. So there are two types, central and peripheral. Both the cases we can use these thiazide diuretics. Remember, the major use of thiazide diuretics is in hypertension. They are the first choice. They are mild antihypertensives, edema conditions. We use it in osteoporosis because they retain calcium. They retain calcium and decrease the risk of calcium stone, and they are used in diabetes insipidus. Why they are used in diabetes insipidus? What is their paradoxic effect? I will discuss that in the next video, that is antidiuretic. Coming to the adverse effect, similar to loop diuretics, they also have the same adverse effect. What is that? Let me write here. The electrolyte adverse effect. the metabolic adverse effect, and others. Now, electrolyte, it decreases potassium, it decreases sodium, it decreases chloride, it decreases magnesium, but one change compared to loop diuretic is it increases calcium. Very, very important. Remember, loop loses calcium, but thiazides retain calcium. Very, very important. So please mark this. And then metabolically, the drug is known to increase uric acid. So if they ask in the exam which antihypertensive you should not use it in a gout patient is thiazides. They are known to increase glucose. They are known to increase the LDL. So they can cause dyslipidemia. So this is the problem with thiazide diuretics. Now the risk is high. So this risk is high when you use high dose of thiazide diuretics. So if you use it at high dose, this risk is high. Risk is low if you are using low dose of thiazide diuretics. So that is what we are using nowadays. What we are using is low dose thiazide diuretics, but there is still risk, but comparatively the risk is lesser compared to high dose. Even the other adverse effect what we see is allergy. Why allergy? Because they are sulfur derived. Second, they can also produce metabolic alkalosis. And you know that these are medium efficacy diuretic. Thiazides are medium efficacy, so they can also decrease ECF. Now compare the adverse effect in loop diuretics. There it was what? Ototoxicity, but here what you see is the erectile dysfunction. So what you see here is erectile dysfunction. So that is what we see with thiazide diuretics. So these are the adverse effects. We have made a list of them. So we know the mechanism of action, site of action. Site of action is early part of DCT, and then we understood the uses and adverse effect of thiazide. So until now, whatever we discussed, and the last part, what I want to tell you is the drug interaction. So can I combine thiazide plus lithium together? So is it rational or irrational? Now problem is whenever you use thiazide or a loop diuretic, what is the problem? They both cause hyponatremia. They both decrease hyponatremia. They both cause hyponatremia. Now what happens when there is hyponatremia? This is the nephron and this is the proximal tubule, the other parts. Now when sodium is lost, the PCT starts reabsorbing more and more sodium. In case of hyponatremia, the PCT starts reabsorbing sodium more and more. Now, sodium and lithium are same compound. The body will take care of sodium and lithium in the same way. So when the sodium is reabsorbed, lithium is also reabsorbed. And you know that lithium has narrow therapeutic index, and when the lithium is absorbed, it will increase the level of lithium and that will lead to toxicity. So patient will have lithium toxicity. So this combination is contraindicated. So thiazide and loop can increase the lithium toxicity. And who can increase it more? Thiazides will do that more compared to loop diuretics. That one drug interaction you need to keep in your mind. So I told you all these drugs what we discussed, they are known to produce hypokalemia. To avoid that, we come with the fourth group of drug. They are called as potassium sparing diuretics. So potassium sparing diuretics. Now how do you spare potassium? How do you preserve that? So I told you these drugs major site of action is collecting duct. So let me write the diagram of collecting duct and explain to you. Yes. So this is the collecting duct. And this is the cell nearby. Okay. So this is the collecting duct and the cell nearby. Now, whenever the sodium enters through a channel, and the channel is called ENaC. So ENaC stands for epithelial sodium channel. Through this, the sodium enters inside the cell. Now this is potentiated by a drug called aldosterone. Now can you tell me from general pharma, aldosterone acts through which receptor? Obviously nuclear receptor. So the aldosterone enters inside, it binds to a receptor called aldosterone receptor, and that will enter the nucleus. So they will enter the nucleus. So when this enter the nucleus, it produces a protein called aldosterone induced protein. So it produces aldosterone induced protein which will increase the sodium reabsorption and it will throw the potassium out. So it will throw the potassium out, and also after some time the H plus goes out. So this is normally happening. Now, how do I protect the potassium inside? I spare it. Number one, if the sodium enters, then only the problem occurs, or you block the aldosterone. So what we do is we block the aldosterone receptor, that is number one target. So we can use aldosterone receptor antagonist. Second is you can block epithelial sodium channel, ENaC. You can block epithelial sodium channel. So there are two important targets for us. Either you block aldosterone receptor or you block epithelial sodium channel. This can be done. Right. Now let us come back and discuss this. Now, when you block this, sodium will not enter, or when you block aldosterone, sodium will not enter. So who stays inside? Potassium stays inside, so leading to hyperkalemia. So hyperkalemia can occur. And when the potassium doesn't go, H plus will also don't go. So patient will have metabolic acidosis. So remember, potassium sparing diuretics, they can produce hyperkalemia. The name itself is telling you potassium sparing, and they retain H plus also inside, that will lead to metabolic acidosis. Now, whenever we give diuretics, for example, when I give loop diuretic, I just want to tell you a concept, loop diuretic or thiazide, what happens? When we give loop diuretic or thiazide diuretic, I told you when they come to collecting duct, this is the collecting duct, and these are the cells. So whenever I give loop diuretic, the sodium enters, who comes out? Potassium comes out, because potassium is not so much in the circulation to compensate that H plus go out. So when we use loop or thiazide, they lose potassium and they lose H plus, leading to hypokalemia as well as metabolic alkalosis. But what is the story of astazolamide? What is the story of astazolamide? That will also deliver the sodium to the collecting duct. So astazolamide can only lose potassium because it will, when the sodium goes inside, potassium goes out. But astazolamide will not lose H plus. It will not lose H plus. So the only ion that has to compensate for sodium loss will be K plus. So it will cause maximum potassium loss, and that is called kaliuresis. Now, if they, in the exam, if they ask you which diuretic causes maximum potassium loss, it is the carbonic anhydrase inhibitor. What is the reason for that? Now, if I use loop or thiazide, they have a compensation. After potassium is lost, the H plus will also be lost. But for astazolamide, H plus cannot be lost. They can only exchange with potassium, so they will cause maximum kaliuresis. This is one of the understanding. Now, come back to the potassium sparing diuretics. We have the aldosterone receptor antagonist and then ENaC inhibitor. They are the targets. So let me come to the target. Number one, in potassium sparing diuretic, what we have is aldosterone receptor antagonist. So these are called aldosterone receptor antagonist. Now, it is also called as mineralocorticoid receptor antagonist. So many times when the question they have given mineralocorticoid receptor antagonist, students are confused. It is also called by that name. Why? Because mineralocorticoid is nothing but aldosterone. The main drug what you need to keep in your mind is spironolactone. The drug is called spironolactone. After the metabolism, spironolactone is converted into canrenone. The question asked is this an example of prodrug? No. Spironolactone is also active. Candinone is also active. One more aldosterone receptor antagonist what we have is eplerenone. So these are aldosterone receptor antagonists. And remember, these drugs can increase potassium and they can produce metabolic acidosis. Very common problem. So once we understand the mechanism of action, remember they can ask in the exam what is the only diuretic which acts from the interstitial side of the nephron. From the interstitial side of the nephron, the drug works are aldosterone receptor antagonist. All other diuretic, if you observe, they act through the luminal side. This spironolactone, eplerenone, they are the only drug which acts through interstitial side of nephron. That is a specialty. Now, once we understand that, we will understand the specialty of spironolactone. Spironolactone has two things. It will block aldosterone receptor. Not only that, it also blocks androgen receptor. It's an androgen receptor blocker. Yes. So keep that in your mind. So let me write the uses of spironolactone. Uses of spironolactone. Number one, why do you use that? To correct hypokalemia due to diuretics. You know that when we use the first three drugs, diuretics, they all cause hypokalemia. How do we correct it? Using potassium sparing diuretic. Number two, it is used in a condition called Conn's syndrome. So Conn's syndrome is nothing but hyperaldosteronism, and it is an aldosterone antagonist. That's why we use it. Number three, it is used in resistant hypertension. So the reason for resistant hypertension is the aldosterone levels are very high. So that is the reason it is used. Number four, it is used in cirrhotic edema. Cirrhotic edema, the diuretic of choice is spironolactone. Please keep that in your mind. Cirrhotic edema, the diuretic of choice is spironolactone. Number five, the drug is also used in chronic CHF. In chronic CHF, it has shown to decrease mortality. It has shown to decrease mortality, that is death rates. Now, in all these conditions, what I mentioned, the aldosterone activity is high. There is increase in aldosterone activity. And how do I decrease it? By using spironolactone. So spironolactone will block the aldosterone and it will prevent the effect of aldosterone. So Conn's syndrome, resistant hypertension, cirrhotic edema is the drug of choice. Chronic CHF, remember the only diuretic which decreases mortality in CHF is spironolactone, that is aldosterone receptor antagonist. Number six, it is also used in hirsutism. Can you take a guess why it is used in hirsutism? Because it has androgen blocking property. And it is also tried in PCOD patients to block the androgen property. These are the uses of spironolactone. Please remember mainly diuretic of choice in cirrhotic edema, because in cirrhosis the aldosterone levels are high, leading to sodium and water retention, and that is going to cause edema. Resistant hypertension also, the aldosterone levels are high, so to compensate that we use this spironolactone. So continuing with the adverse effect of spironolactone, I told you all these drugs can increase potassium and they can cause metabolic acidosis. And importantly, the drug can cause gynecomastia and loss of libido. So the drug can cause gynecomastia and loss of libido. Can you tell me what is the reason for that? The reason is it's an androgen blockade, and that's the reason it will cause gynecomastia and loss of libido. In female, it has shown to produce menstrual irregularities. The reason is it has shown to block progesterone receptor in females. But mainly they will ask in the exam is the drug diuretic causing gynecomastia is spironolactone. What about eplerenone? Eplerenone, everything is same to same like spironolactone, but only advantage is no androgen blockade. So it doesn't have androgen blockade, it doesn't have the progesterone blockade, so there is no risk of gynecomastia, loss of libido. Otherwise, everything what we discussed for spironolactone, the uses, adverse effect, all are same for eplerenone. So that is the important point. Now moving on to the next potassium sparing diuretic, it is the epithelial sodium channel blockers. So these are called epithelial sodium channel blockers or ENaC inhibitors. The main drug is called amiloride. It is called amiloride, and where to use it? It is used in the management of cystic fibrosis. Second, it is used in Liddle syndrome. Liddle's, it is used in Liddle's syndrome. So what is the problem with Liddle syndrome? The problem with Liddle syndrome is these ENaC channels are hyperactive. So they will retain more and more sodium and water. So we want to block it. Second is it is used in one more condition called lithium induced diabetes insipidus. So amyloid is the drug of choice for lithium induced diabetes insipidus. Now why it is the drug of choice? The reason is here. I'll write again the collecting duct for you. This is the collecting duct and this is the cell nearby. Now I told you there is a channel called ENaC through which sodium enters. Through the same channel, the lithium enters. When the lithium enters, it will enter and decrease the activity of ADH. So what is ADH? Antidiuretic hormone. When you decrease that effect, so the patient will have diabetes insipidus, and that is what we mean by lithium-induced diabetes insipidus. So if lithium enters inside, then only the diabetes insipidus. So when we use amiloride, it blocks the entry of lithium, and it will treat the lithium-induced diabetes insipidus. That's why it is the drug of choice for this. Sir, will the epithelial sodium channel blocker cause hyperkalemia? Yes. Will they cause metabolic acidosis? Yes, they will also produce this problem. Now, another ENaC inhibitor, the name is called triamterene. It is called triamterene, and one of the adverse effect of the drug is it can cause megaloblastic anemia. It can cause anemia called megaloblastic anemia. So this is about the potassium sparing diuretics. Until now, I have discussed the loop diuretic. First of all, we started with carbonic anhydrase inhibitor, loop diuretic, thiazide diuretics, and we discussed potassium sparing diuretic. The fifth target, what we need to understand is the osmotic diuretics. They are called osmotic diuretics. Example is, basically you should remember the drug mannitol and a drug called glycerol. These are the major drugs. Apart from that, we also use urea and isosorbide. These are also called as osmotic diuretic, but most of your exam question is on mannitol. Now, what is the mechanism of action of mannitol? Let me explain to you. Now, mannitol has two important site of action. It's not only in the kidney, it acts on the tissue, at the level of tissue. Suppose if I take the example, patient is having a cerebral edema. So we have a blood vessel here. This is the blood vessel and patient has cerebral edema. So there are cells inside. There are cells inside the tissue. So water is excessive and that's why we call it as cerebral edema. Now when we give mannitol, mannitol enters in the blood vessel and it is osmotic agent. So osmotic agent pull the water into the blood vessel. So the water increases. So when the water increases in the blood vessel, there is a decrease in the pressure inside. Suppose the tissue is brain, the cerebral edema decreases, the intracranial pressure decreases. If it is the eye, the intraocular pressure decreases by drawing the water from the tissue into the blood vessel. Now when it draws so much of water into the blood vessel, what happens to the blood volume? it increases. So the ECF volume increases. Now when the blood volume increases, the volume will be given to the heart, and heart has to work more because the blood volume is more, it has to pump more. So when it pumps it from the heart, it will reach the nephron. It will reach the nephron. So in the nephron, I told you it can act through the entire nephron, but the major site of action is in PCT. Since it is a osmotic agent, it will not allow water to go out of the lumen. So water stays in the lumen, and you can see loss of water, that is massive diuresis. So there is massive diuresis. Along with that, there is electrolyte abnormalities. So when we use osmotic diuretics, they will cause massive diuresis, they cause massive diuresis and electrolyte abnormality. Now, because of this, they decrease the pressure. They are used in cerebral edema, and they are used in an emergency in glaucoma, that is acute congestive glaucoma. Acute congestive glaucoma. Now remember, can we use this drug in pulmonary edema? That's the basic question. Now remember, whenever there is pulmonary edema, what is the problem in pulmonary edema? This is the lung, and pulmonary edema, the left ventricle has failed. Now when the left ventricle has failed, the pulmonary edema has occurred and the back pressure is on the lung. So can we use mannitol in a patient with pulmonary edema is a bigger question. Can we use it? What is your answer? Pause the video and tell me. Can we use it in pulmonary edema? No. The reason is, when you give mannitol, it increases the blood volume. So when you increase the blood volume, there is increase in workload on the heart. When the workload on the heart increases, already the left ventricle has failed, it will fail further. And if it fails more and more, the pulmonary edema worsens. So that's the reason mannitol is contraindicated in pulmonary edema as well as left ventricular failure. Again, important point here is, suppose there is head injury and bleeding. So what happens if there is head injury and bleeding? Let me take, this is the brain tissue, and let me draw the blood vessel. So blood vessels are damaged because of head injury and there is bleeding. Now if I use mannitol in that patient, what happens? Mannitol will leak out from the blood vessel. What happens if the mannitol leaks out? The mannitol will draw more water, and more the water, the intracranial pressure increases and it will worsen the cerebral edema. So if the patient has head injury and he has active bleeding, we don't use it. But if there is no active bleeding, you can use it in cerebral edema. So how do we know that, sir? By CT scan. If the bleeding is active, don't use mannitol. So these are the concept I just want to tell you about mannitol. Now let me summarize the uses here. What are the uses of mannitol? Mannitol is the drug of choice for two conditions: cerebral edema. Second one is acute congestive glaucoma. So two places it is a drug of choice. Number two, it is also used in poisoning. Why it is used in poisoning? So that you can eliminate the poison easily by diuresis. Then we can also use it in impending renal failure. Now what do you understand by the term impending renal failure? Impending renal failure means kidney is still functioning, some urine is coming out, so there is something called oliguria which is seen. Now how come it will help? You know that it increases the blood volume, it will increase the urine formation by increasing the vasodilation, so the more urine flows out. So you know that it increases the ECF volume, the blood volume, the renal blood flow increases. When the renal blood flow increases, the urine output increases. Okay, so that's the reason we use it in impending renal failure. I'll explain again. When we use mannitol, mannitol increases blood volume. When you increase the blood volume, the renal blood flow increases, and when the renal blood flow increases, the GFR increases. When the GFR increases, the urine output increases. That is what we require in oliguria. Now coming to the contraindication of mannitol, this is very commonly asked in your exams. It is contraindicated if there is cerebral hemorrhage. If there is active bleeding, we don't use the drug. If there is active bleeding, we don't use it. We don't use it in pulmonary edema. You know the reason, I have explained that, or left ventricular failure. We don't use it in renal failure. Already the kidneys have failed, we don't use it. Now, when the kidney has already failed, then if I use mannitol, what happens? The ECF increases, and when the blood volume increases, the kidneys are not working, so edema worsens. And mannitol also causes electrolyte abnormalities, which will worsen the renal failure further. So already if the patient has failed kidney and anuria, don't use mannitol. If it is about to fail, you can use it. But when it's already failed, don't use mannitol. So that is about the osmotic diuretics. So once we understand this, let me summarize the thing. Please understand diuretics are the drugs which are known to eliminate sodium and water in the urine. The major drugs are carbonic anhydrase inhibitors, then we have loop diuretics, thiazide diuretics, potassium sparing diuretics, and osmotic diuretics. Please understand the mechanism of action, very commonly asked, uses. I have mentioned where the drug of choices are asked. Now, apart from that, is there any other drug which have diuretic action? Yes, there is a drug called nesiritide. Nesiritide is a BNP analog, and BNP stands for brain natriuretic peptide. It also has diuretic property because it loses sodium. When it loses sodium, there is loss of water also. So nesiritide has that diuretic property. Even the sodium glucose transporter 2 inhibitor, SGLT2 inhibitor, like I'll give an example, empagliflozin, dapagliflozin. Now they are losing sodium as well as glucose. So by losing sodium and glucose, they act as diuretics. So these also have diuretic action, but this is for your additional information. That's it. Okay, so this is about the diuretics, and the next video will be discussing something called antidiuretics. Thank you all.